Hi, and welcome to my presentation on the research proposal for the effects of thiamine supplementation on lactate levels in critically ill adults. My name is Monica Moore. I'm a registered dietitian at Southern Maine Healthcare in Biddeford and a University of New England master's candidate. Here's the overview of what we're going to be discussing today at this proposal presentation. We're going to include some background, objectives, subjects, research setting, methods and procedures, confidentiality, data analysis, and anticipated results and conclusions. Thiamine, also known as vitamin B1, is a water-soluble vitamin. It's found in the bloodstream, but only in small stores. It's affected by the systematic inflammatory response system, also known as SIRS. Deficiency is prevalent largely because of the small stores that the bloodstream carries. Deficiency can lead to Korsakoff syndrome, Wernicke's encephalopathy, and neurological issues. These can also lead to symptoms such as falls, confusion, poor overall outcomes, mortality, and many other issues. Sepsis is defined by characteristics such as systemic arterial hypotension, tissue hypoperfusion with organ dysfunction, and hyperlactatemia, which is high lactate levels. Newer definitions include a more sensitive serum lactate marker of over 2 millimoles per liter. Previously, it had been over 4 millimoles per liter. This is possibly suggesting the importance of serum lactate levels as a marker for sepsis. Elevated lactate production and the reduction of clearance contribute to these elevated serum levels and can worsen critically ill status. Lactate levels are shown to normalize with recovery of septic shock. Mortality rates in sepsis are 28.3% in the US and up to 41% in Europe. In addition to just mortality, sepsis costs over $20 million in the US for care. When we look at these two things of thiamine and sepsis together, there's an overlapping issue here. Thiamine can be a metabolic resuscitator. It promotes aerobic metabolism and can lead to decreased lactate production, improved levels. And as we were talking about in the previous slide, improving lactate levels can go hand in hand with recovery from sepsis. So therefore, if we can improve lactate levels sooner, possibly with the use of thiamine, it can lead to quicker sepsis resolution, which can improve overall mortality and reduce care costs of sepsis. There are currently many studies that have investigated and are still investigating this relationship. However, a literature gap does exist in dosing, timing, and frequency recommendations for thiamine supplementation in this population group. Recent studies are inconsistent on interventions and the effects on sepsis and critical illness. More research is absolutely needed. Higher prevalence of thiamine deficiency at hospital admissions is also noted in these research studies, and also higher than previously thought, which is another interesting point that the thiamine being improved could contribute to better results overall in septic patients. Narrowing down recommendations could improve overall outcomes, reduce mortality, and contribute to the standard of care in this population potentially being altered. So with all that being said, objectives for this research proposal are to determine the effect of IV thiamine supplementation early in admission on serum lactate levels and thiamine levels in those critically ill hospitalized patients with sepsis. A secondary objective is to assess the prevalence of thiamine deficiency among critically ill at baseline when admitted to the hospital. While that is not directly related to sepsis, it will be interesting to see how many patients admitted with critical illness and sepsis are thiamine deficient and therefore could lead to further studies specifically related to improvements with deficiency and overall outcomes. The subjects for this study will be those over the age of 18, have a diagnosis of sepsis or septic shock, and that was discussed in the earlier slides on sepsis, what that includes for criteria. Anticipation of more than 24-hour hospital stay. It will include both genders and all ethnicities without exclusion. The exclusions will be under 18 years old, prior thiamine supplementation, whether it be prior to inclusion in the hospital or prior to admission, and end-of-life goals of care, where the goals are really just comfort-focused and not necessarily aggressive interventions. Based on G-Power analysis, 176 participants at least will be needed for this study. Split up, that's 80 patients per group. Hospital admission recruitment will be the method of recruiting these patients. So when they are admitted to the hospital, if they meet the inclusion criteria and they do have elevated lactate levels, they will be included into the study. Informed consent will be obtained from the patient or the POA, dependent on the patient's ability to provide it themselves, and no compensation will be provided for participating in this study. The research will be performed at Southern Maine Healthcare in Biddeford, Maine. As previously stated, consent will be obtained at the time of admission when able from the patient. Otherwise, the power of attorney or next of kin family member can provide consent as well. With sepsis, as we talked about some of the symptoms of these high lactate levels with both sepsis and with thiamine deficiency, confusion can be a part of that, so patients may not be able to necessarily sign for themselves. The clinical staff at the hospital will perform the interventions and collect the data to give to the researcher. Electronic medical records will additionally be used for data collection and intervention administration tracking. That hospital at Southern Maine Healthcare in Biddeford uses Epic as their electronic medical record system. It will be a randomized controlled trial, although not blinded. The staff will know whether they are giving thiamine or not, as will the researcher. Subjects randomized into the intervention or control groups at inclusion will either receive the intervention, which is IV thiamine of 200 milligrams within the first 24 hours of admission, and 100 milligrams IV daily thereafter. The control group will receive no supplementation or placebo. And unfortunately, this is another reason that both participants and staff will know whether or not they are getting the intervention, since there is no placebo being given for the other group. Interventions will continue until discharge or until 7 days of supplementation is reached, whichever comes first. Each patient that's included into the trial will be coded with a number. This number will be used when their labs and their data is passed along from the clinical staff at the hospital to the researcher in order to keep their confidentiality and not give personal identifying information. Labs will be checked at admission and daily thereafter for serum thiamine and serum lactate levels. These will be added to existing daily lab draws that are already done in the hospital in critically ill patients, so therefore will not add any additional sticking lab drawing or discomfort for the patient. Administration of thiamine will be documented into the chart flow sheets by nursing. Data and intervention administration information will be collected by the clinical staff and sent to the researcher via this number-coded system we were just discussing over email, and the researcher will keep a spreadsheet with all of the data. As far as confidentiality, when we think about data being passed back and forth, personal identifying information will not be shared with anyone, including the researcher. That's why they will be coded with a number at inclusion for the data reporting. The researcher will not have access to electronic medical record. Spreadsheet with data will be kept on a password-protected laptop by the researcher, and only medical information or data that is pertinent to the study will be shared with the researcher, and those will be laid out ahead of time what that information will include. Consent forms that are signed by the patients or the powers of attorney will be kept in the patient's chart, and the chart itself is protected by HIPAA. For data analysis, since we are collecting quantitative data, we will be using an independent t-test for significance between means of each outcome, the serum thiamine from start to finish of the study and the serum lactate from start to finish of the study. We'll be looking at this difference between means of each of those. The null hypothesis will be considered rejected if the p-value is less than or equal to 0.05. To illustrate, graphs of the difference in outcome means between IV thiamine and the control group will be used, and a pie chart to illustrate the percentage of participants with thiamine deficiency at admission will also be displayed. Looking at risks versus benefits is something, especially in IRB proposals, that is important because we want to do no more than the minimal risk involved in participating. And this study it has no more than the minimal amount of risk involved. Potential benefits, however, could be improved overall health outcomes, quicker improvement of sepsis, decreased hospital complications, decreased hospitalization length of stay, decreased time on mechanical ventilation or vasopressor support, and improved thiamine levels. Anticipated results of the study, based on previous studies done and based on research connecting the effects of thiamine on sepsis and lactate levels, would suggest that an increase in serum thiamine levels will be seen from start to finish in the thiamine supplemented group, which is our intervention group, and a significant difference will be seen compared to the control group in the increase in thiamine levels from start to finish, as this chart demonstrates. Another anticipated result is that there will be a decrease in serum lactate in thiamine supplemented group from start to finish, and a significant difference between the thiamine group and the control group in lactate reduction over time, as demonstrated in the chart to the left. Additionally, as far as our secondary outcome of thiamine deficiency assessment is concerned, we expect to see the percentage of critically ill patients at admission with baseline thiamine deficiency. Previous studies have suggested anywhere from 10 to 20 to 30% of patients in different studies have been shown to be thiamine deficient, even though that wasn't necessarily what the researchers were looking for. So a study looking specifically at that as a secondary outcome would be interesting to see the percentage, especially since this study will be a little bit larger at 176 participants minimum, whereas previous studies have been smaller and therefore harder to tell the significance and the percentages of deficiency. Conclusions are to be determined. Since this is a research proposal, we haven't done our research yet and haven't come up with actual results, but it will be interesting to see what comes out of it. I have no conflicts of interest to disclose, and there's no funding or financial disclosures to report for this project. And this was submitted for IRB proposal through the University of New England in June of 2020. Now we have some time for questions. While you're thinking of questions and while we do a little Q&A session, here are the references. Thank you for attending my presentation.